Hello student. Now we are going to discuss another topic in respiratory physiology, a very important topic, that is lung volumes and capacities. So in this session what we are going to learn, first of all we are going to discuss spirometry, okay, and with the help of spirometry we are going to discuss various lung volumes and capacities. Then we are going to discuss closing volume and closing capacities, and we are going to understand the difference between obstructive and restrictive diseases in terms of lung functions. And then we are going to discuss the digital spirometry and flow volume loop in respiratory system, and at the end abnormal flow volume loop will also be discussed, and obviously at the end of the session we are going to discuss few MCQs. So this is our plan. So now let's start with the first thing, that is the spirometry. So whenever we say lung volumes and we all know that the lung volumes and capacities is measured with the help of an equipment which is known as the spirometer. So what is spirometer? So look at this system. So it's a closed chamber. In that closed system or in that closed chamber, you have to take breathe in and breathe out. So look at here. So this is the drum. This is the floating drum. It is floating on the water, and inside this drum there is normal air. So normal air is kept inside this drum, and this air is sealed. I told you that it's a closed system, so you have to seal the air so that there is no leakage of the system. And to seal the air, there is an water jacket outside this air sealed drum, right? So this drum is there. Inside the drum there is air, and from the drum you have to take inspiration and expiration. So if you look at this diagram more closely, then you are finding out here that there is a tube, and this tube is ultimately connected with the mouth of the subject, which is known as the mouthpiece. So whenever you connect the subject at the level of this mouthpiece, so the subject has to take this portion into the mouth, and then you have to close the nose. Now if the subject is taking one inspiration, okay, so what will happen? So he is going to take some air. So where from the air is coming? The air is going to come from this drum. So what will happen whenever the person is taking inspiration, okay, so he is going to take some of the air from this drum which is there in the system. So what will happen? The drum will go in the downward direction because you are decreasing the volume of the drum. Now look at here. The drum is connected with some thread, and the thread is connected with some pulley, and this thread is ultimately connected with the writing pen here. Okay, so the thread is ultimately connected with the writing pen. So now you try to understand that if the drum is moving in the downward direction, so this part of the thread is also going in the downward direction. So what will happen? This part of the thread is going to move on the left hand side, and the pen thread, the thread which is connected with the pen, that is going to move in the upward direction. Means whenever the subject is taking one inspiratory movement, what is going to happen? The pen is going to move in the upward direction. So for upward direction, the pen is going to move in the during inspiration, the pen is moving in the upward direction. Getting my point? Now just think of the opposite thing. So when the person is doing the expiration, I told you, okay, that this is a closed system. So during expiration, the subject is going to exhale in the same system only. So whenever the subject is exhaling into this system, what will happen? It will increase the volume of the air in the drum. Okay, so first the drum will go in the downward direction during inspiration. Now the drum is going to float in the upward direction. So if the drum is moving in the upward direction, so what will happen to the movement of the pen? The pen will go in the downward direction. So the expiration means there will be downward movement of the pen. So this upward and downward movement of the pen will be recorded by a recording drum. So this recording drum will move slowly at a particular speed, and onto the surface of the drum, the pen is going to write the movement of the pen, right? So this way, the pen is recording the inspiratory and expiratory effort of the subject. Now here one thing you have to note down, that whatever amount of air the subject is taking during inspiration, or whatever amount of air the subject is exhaling during the expiration, that volume of air is going to be recorded by this pen. So what the pen is going to write here? The pen is going to record the volume of air which is going in or out of this drum, right? Now with this basic concept, you are understanding the spirometer is recording the various volumes of our lung. The volume which is going into the system, spirometer, or it is going into my body from the system, right. So another diagram I will show you, the same diagram of the spirometer. So here it has been shown that this tube which is connected inside this floating drum, so you can find here the floating drum. So the tube is connected at the center of this floating drum. So whenever the subject will take inspiration, the drum will go in the downward direction and the pen will move in the upward direction. So look at here, the recording has been shown on your right hand side. So as you can find out here, the upward movement of this recording on the surface of the drum is the inspiratory movement, right? And the downward direction movement of the pen is nothing but the expiration. So expiration means the pen is moving in the downward direction. So never forget that in normal spirometer, conventional spirometer, the upward movement is inspiration, the downward movement is expiration. Now with this concept, we are going to discuss the various lung volumes and capacities. So before that, try to understand what is the meaning of lung volumes. As I told you already, the volume of air which is entering in the volume of air in the lung at a specific point of point during breathing is known as the lung volume. So volume means it's a specific volume of air, okay. And whenever we say lung capacities, right, so capacities is the combination of, or it is the sum of various volumes. So it is the sum of different lung volumes. So that means simply if you add up 2-3 more volume, then that addition of the volume is known as the lung capacity. So capacities is equal to multiple volume adding up, right. Now whenever we discuss lung volumes and capacities, you have to remember that it is are of two types: static lung volumes and capacities and dynamic lung volumes and capacities. Now whenever we say static lung volumes and capacities, you have to remember that here we are measuring only the volume of the lungs, okay, not the time. Here we are not going to measure the time, right. But whenever you are measuring the various lung volumes and capacities with respect to time, okay, then that is known as the dynamic lung volumes and capacities. So in case of static lung volume capacities, what will be the unit of the measurement? The unit will be equal to the either in ml or you can measure in liter. But in case of dynamic lung volumes and capacities, what will be the unit? Unit will be equal to the ml per minute, that is maybe in second or maybe in minute, right. Same way, so liter per second or liter per minute can also be an unit of dynamic lung volumes and capacity. So the basic difference is that if you are measuring only the volume without any time measurement, then that is static, and if you are measuring volume with respect to time, that is dynamic. Now first we are going to discuss the static lung volumes in our lung, okay. So to understand this recording, you have to just think of the spirometer. So spirometer, whenever it is recording, we have already seen that the movement will go in the upward and downward direction. So the y-axis of this recording will be the volume axis. So y-axis is the volume recording, and what will be the x-axis? The x-axis is time axis. But in dynamic and static, I told you that in static volume we are not going to record the time, so only we are going to measure the volume. So during recording of the static lung volumes, what instruction you have to give to the subject? So first of all, you have to connect the spirometer at the mouth of the subject, then you have to close the nose, and then you ask the subject to take normal inspiration and expiration. So inspiration means the curve will go in the upward direction, expiration means the curve will go in the downward direction. So inspiration, expiration, 3-4 breathing, it will go like this. Then you ask the subject that take a deep inspiration. So after few normal breathing, now you ask the subject to take a deep inspiration. So whenever the person will take a deep inspiration, so you can understand that this curve will move in the upward direction and it will go in the maximum upward direction, okay. So after taking the maximum inspiration, your lung will be filled with the air. So maximum volume of air that can enter inside the lung, that is means this is the peak point. So the peak point indicate the maximum volume of lung already has entered, okay. So after taking a deep inspiration, now you ask the subject to take a deep expiration, to do a deep expiration, full expiration or maximum expiration. So whenever the person will do the forceful expiration, the curve will move in the downward direction like this, and then he will not be able to expire forcefully more. So what will happen? After that, you ask the subject to return back to the normal breathing. So again he will return back and few normal breathing, and then you stop the maneuver. Okay. So, this maneuver, if you done by any subject which is connected to the spirometer, you are going to record the various static lung volumes, okay, and capacities also. So, from this recording, what we are going to do? So, y-axis we know that this is the volume axis and x-axis is the time axis. So, suppose this volume axis, that is the y-axis, started from the 0 volume, okay, 0 volume. So, from this 0, I can understand that one part of this volume is there which is not recorded in the spirometer, which is not recorded in the spirometer. So, this portion where I have just highlighted, there is no recording, although there is certain volume. So, from this 0 up to a certain level, there is no recording. So, this volume which is not recorded in the spirometer, that is approximately 1300 ml, approximately 1300 ml, and this volume is known as the residual volume, RV, residual volume. So, all of you know that the residual volume means this is the volume which always remain inside the lung. Remain inside the lung means it is not going into the spirometer or it is not going out of your lung, right? So, if it is not going out of your lung, then it is not going to enter in the spirometer, and if it is not entering in the spirometer, so there will be no recording. So, that is why we are not getting any recording in the volume which is 0 to 1300 ml. So, this 1300 ml volume is known as the residual volume. Now, if I ask you that from this recording, could you find out that what is the normal volume of air which is going inside your lung or going out of your lung? This is very easy. So, what I am going to do? So, upper part of this normal inspiratory effort and the lower part of this normal expiratory effort. So, if I do a measurement of volume in between these two, then this is the volume which is entering inside my lung during normal inspiration, or it is going out of the lung during normal expiration. So, during normal inspiration and expiration, the volume of air which is going in entering into your lung or going out of your lung, that volume is known as the tidal volume. That volume is known as tidal volume, right? So, normally the tidal volume is 500 ml to 700 ml. So, you will remember that it is 500 ml. Now, after taking a normal tidal volume, if I ask you ki do a forceful inspiration, so we have already seen that. So, that during forceful inspiration, the curve is moving maximum up to this peak point, and that is the maximum inspiratory effort that can be done by this subject. So, now if I want to calculate that what is the extra volume of air going inside the lung with a maximum inspiration. So, I can find out by this recording. So, look at this arrow. So, this is the volume which is entering inside the lung with maximum inspiratory effort, okay, above the tidal volume. So, tidal volume is already entered here, tidal volume is already entered here. After the tidal volume, the extra volume of air which is going inside the lung with maximum inspiratory effort, this is known as the inspiratory reserve capacity, inspiratory reserve volume. Getting my point? So, this volume is known as the inspiratory reserve volume, right? So, this is normally remain in reserve condition. If you require extra inspiration, if you require extra amount of air, fresh air into your lung, then you have to utilize this portion. So, that is why this is known as inspiratory reserve volume. Normally, it is in reserve inside your lung. Okay. Now, same way, if I want to find out that what is the extra amount of air the subject has exhaled during forceful expiration. So, what is the extra amount of air the subject has expired with forceful expiration? So, this black color arrow will indicate that, okay, that this is the excess amount of air which can be expired by the subject with force, with additional force. So, normally this expiratory air also remain reserved inside your lung. Normally it is not used, but whenever you are taking forceful inspiration and expiration, this expiratory reserve volume is going to be used. So, this is known as expiratory reserve volume. So, inspiratory reserve volume and expiratory reserve volume, and already I told you that the volume which is not entering in the spirometer, which always remain inside the lung, that is known as the residual volume. Okay. So, now if I write down the amount of this, so inspiratory reserve volume is generally 2000 ml. So, 2 liter to 3 liter. Okay. So, most of the books are saying, including Genong, it is saying 2 liter, right? Then tidal volume we have already discussed, that is 500 ml. Expiratory reserve volume is 1000 ml. Some books are saying 1000 ml, but some of the books are saying that it is 1200 ml, right? And a reserve volume is generally 1300 ml, right? 1300 ml means if you look at the scale in the y axis, then you will find out that this is 2300 ml, okay? This will be the 2800 ml because tidal volume has been added up here, okay? And then this peak point or the maximum will be 4800 ml. Now this 4800 ml is the maximum amount of air that can be accommodated by the lung in this person. So, and this maximum amount, this is known as the total lung capacity, we will discuss, okay. So, these are the 4 different lung volumes that we have discussed so far, and already we have discussed that a residual volume cannot be measured with the help of spirometer. Residual volume cannot be measured. So, residual volume cannot be measured, okay, measured with spirometer, right. So, what is required? I will tell you that what is the method by which residual volume can be measured. But before that, you have to understand that what are the various lung capacities. So, I told you that capacities means that is the addition of various lung volume. So, inspiratory capacity. So, we all know that inspiratory capacity means tidal volume is added up with inspiratory reserve volume, and this is known as the inspiratory capacity. Then vital capacity, this is tidal volume plus inspiratory reserve volume plus expiratory reserve volume. So, if you combine these 3 volume, then that is known as the vital capacity. FRC, that is the functional residual capacity, we have discussed multiple times that if you add up ERV, expiratory reserve volume, and residual volume, then the combination of this is known as the functional residual capacity. We have discussed multiple times that this is known as the resting lung volume or relaxation lung volume, and this is the volume of the lung which will remain inside after normal expiration. After normal expiration, look at here. So, inspiration, expiration, inspiration, expiration, inspiration, expiration. So, at the end of normal expiration, what is the volume of air which is remaining inside the lung? Both the residual volume is remaining and expiratory reserve volume is remaining. If I combine these two, what is the meaning of that? That is known as the functional residual capacity. And obviously, the total lung capacity will be combination of TV plus IRV plus ERV plus your residual volume, means combination of all. Now, I told you that residual volume cannot be measured with the help of spirometer. So, wherever this residual volume is there, like for example, FRC as well as the TLC, residual volume is one of the component of these two capacities, FRC and TLC. So, FRC and TLC also cannot be measured by spirometer directly, because if you want to calculate what is the volume of FRC, then you require residual volume. If you want to calculate total lung capacity, then also you require the residual volume. So, what is the methods by which residual volume can be measured? So, residual volume, okay, measurement can be done by 3 method, okay, and those 3 method name you have to remember. Number 1 is helium dilution method. So, this is the most common method for measuring the residual volume, easy to measurement, okay. Second method is the nitrogen washout method, nitrogen washout method, right. So, nitrogen washout method we have discussed previously also that it is also used for the anatomical dead space measurement, but for anatomical dead space measurement single breath nitrogen washout method is used, and here there is a modified version, that is a multiple breath nitrogen washout method is used for calculating the residual volume. And number 3 is known as the body plethysmography. Body plethysmography. So, the body plethysmography is the best method among all these 3 which is used to calculate the residual volume, right. So, all these 3 method name you have to remember, and you also have to remember that body plethysmography is the best for measurement of the residual volume, okay. Now, after discussing this static lung volumes and static lung capacities, we are going to now discuss the closing volumes and closing capacities. So, this is a different term which cannot be measured with the help of spirometer again, right. So, closing volume and closing capacities also cannot be measured with the help of spirometer. But before that, we have to understand that what is the closing capacity, okay, and closing volume. So, suppose this is the diagram of the lung, okay. So, in this diagram, suppose the subject is in upright posture, means in the sitting posture or maybe in the standing posture. So, we have already seen in previous chapter that whenever the person is in an upright posture, then the size of the alveoli at the apex is very huge in comparison to the size of alveoli in other parts. So, if I draw alveoli in three different zones, one is the apical alveoli, one is the middle zone alveoli, and one is the basal part of the alveoli, then all of you know from previous discussion that the size of the alveoli is smallest at the level of base of the lung, okay, followed by middle, and apical alveoli means they are the largest in size. Now, think of if I do a forceful expiration, then what will happen to these different alveoli? Okay, normal, that is a deep inspiration. So, suppose after taking a deep inspiration, the alveoli has been expanded and apical alveoli is hugely expanded, followed by middle part, followed by base. Now, whenever I do a forceful expiration, so suppose now I am doing a forceful expiration, forceful expiration. So, whenever you do forceful expiration, what you do? You apply force from your thoracic wall. That means you are trying to squeeze out the lung, both the lung you are trying to squeeze out. So, whenever you are applying force from outside, from the chest wall, what will happen? All the alveoli which are there inside your lung, they will be compressed. Okay. That means the alveoli which are there at the level of apex, there will be reduction in the size of this alveoli gradually. So, more compression means more will be the reduction in the size. Same way there will be reduction in the size of the middle part alveoli, and same way there will be reduction in the size of the basal alveoli also. So, if you go on this forceful expiration, if you go on doing this forceful expiration continuously, means if you maintain this force, compression force on the chest wall, what will happen? One condition will reach where almost all the alveoli which are there in the lung, suppose this is the apical alveoli, this will also be closed. Okay. So, suppose this is the apical alveoli, this will also be closed. Okay. The middle part alveoli, this will also get closed, and the basal alveoli, this will also get closed. Getting my point what I am saying? So, one condition will reach where if you go on continuing this forceful expiration, okay, what will happen? Lung size will reduce, and with the reduction in the lung size, what will happen? The alveolar size will also reduce, and ultimately one point will reach where this small size bronchioles is going to get collapsed. The small size bronchiole is going to get collapsed. Now, whenever these bronchioles are getting collapsed in basal part, middle part as well as apical alveoli, means I can say that in this condition, because of this forceful expiration, what has happened? All the alveoli are closed up. All alveoli are closed off. Closed off. Now, whenever all alveoli are closed off, in that condition, if you do more forceful expiration, do you think you are going to expel out more air from this alveoli? Answer is no. Why no? Because already these alveoli are closed. Why it is closed? Because of the closure of the smaller size bronchioles. So, before the complete collapse of the alveoli, there will be closure of the bronchioles because bronchioles diameter is smaller than that of the alveolar diameter. So, if you do a forceful expiration, one point will reach where all of the alveoli in the lung will be closed because of the closure of the smaller size bronchioles. Now, whenever this scenario appear, in this condition, the amount of air which is still remaining inside the alveoli of the apical part as well as in the middle part as well as in the basal part alveoli, if you combine all of the volume of air inside all of these alveoli, then that volume is known as residual volume. So, this is residual volume, this is residual volume, this is residual volume. Getting my point? So, why residual volume is not coming out of the lung? This is the explanation, that if I do a forceful expiration like this, what will happen? At the end of this forceful expiration, inside my lungs, all the alveoli will be closed off. Why the alveoli will be closed off? Because of the closure of the smaller size bronchioles. And whenever all the alveoli are closed off, the remaining amount of air which is still there inside the alveoli, they are known as the residual volume. So, now if I ask you that during residual volume, all the alveoli are closed off, but the closure of the alveoli is starting from which part of the lung? Basal part, middle part or apical part? So, look at the size of the alveoli. Initially, the size of the alveoli is largest in the apex, middle part followed by middle part followed by base. So, if I ask you that there will be closure of all the alveoli at the end of the forceful expiration, but before that, closure is starting from which part of the lung? Then you can easily understand that the closure will start from the base of the lung. So, one condition will reach where the basal lungs alveoli are closed, but the middle part alveoli are still open and the apical part alveoli are also still open. So, if I go on if I go on forceful expiration more and more, first one point will reach where only the basal alveoli are closed up. Only the basal alveoli are closed up, but apical alveoli is also open and the middle part alveoli are also open. So, this is the scenario where only the basal alveoli are closed up. In this scenario, if I measure that what is the remaining volume of air in the lung, that means remaining amount of air is there in the apical alveoli also, middle part alveoli also and base of the also, then this is known as the closing capacity of the lung. So, what is the definition of the closing capacity? When basal alveoli are closed off, basal alveoli are closed off, okay, but the apical and uppermost alveoli are still open. In this condition, the remaining amount of air which is still there inside the lung is known as the closing capacity. Getting my point? Getting my point? So, if I do a forceful expiration, first there will be closure of the basal alveoli. At that point, the remaining air is known as the closing capacity. Then there will be closure of the middle part alveoli. Then there will be closure of the apical alveoli. When all the alveoli are closed off, then the remaining amount of air which is still there in the lung, that is known as the residual volume. So, first whenever you do a forceful expiration, first you will reach at the level of closing capacity. Then if you continue the forceful expiration, some more air will go out of the lung from this apical alveoli as well as from the middle part alveoli, and then very little amount of air is going to remain inside the lung, and that little amount of air is known as the residual volume. Getting my point? Okay. So, basal alveoli are closed off, the volume which is still there in the lung, that is closing capacity. So, now we are going to discuss this closing capacity with the help of normal spirometer recording. So, normally we are taking inspiration, expiration, inspiration, expiration. Now, if I ask the subject to take a deep inspiration, so he will reach to the maximum point. Now, the subject is doing forceful expiration, and at the end of forceful expiration, suppose he is reaching here and then again normal. So, now I know that at the end of this forceful expiration, the volume which is remaining in the lung, this is residual volume. What is the condition of alveoli at residual volume? All alveoli are closed off. All alveoli are closed off, right? All alveoli are closed off. Now, I also know that during this forceful expiration, one point will reach where only the basal alveoli are closed off, In this condition, the remaining amount of air which is still there in the lung is known as the closing capacity, means from this 0 ml up to this ml, this is known as closing capacity. So, in closing capacity, what has been happened? Only the basal alveoli are closed off. Only the basal alveoli are closed off. Okay, only the basal alveoli are closed off, but the apical and middle part alveoli are still open. So, obviously, from this diagram, I can easily understand that even after forceful expiration, the volume which still remain inside the lung, that is known as the residual volume. Okay, and when the basal alveoli are closed off, this is known as the closing capacity. So, obvious thing is that the closing capacity is very greater than that of the residual volume. There is no confusion in that, but you also have to remember that the closing capacity is equal to the closing volume plus residual volume. Getting my point? That means if I ask you from here that what is the definition of closing volume, your answer will be closing volume will be equal to the closing capacity minus your residual volume. Closing capacity minus your residual volume. So, basically that this is the portion which is my closing volume. So if I add up this closing volume and residual volume, what I am going to get? I am going to get this closing capacity. Fine. Okay. So now you tell me that closing capacity is less than or more than functional residual capacity. So which one is the functional residual capacity here? If I measure the two volume, then this is the FRC. So this highlighted portion is the FRC. So obviously you can find out from this diagram that FRC is normally higher than that of the closing capacity. So that is written here, that normally in normal individual closing capacity is lesser than FRC. Not only that, closing capacity is almost 50% of the FRC. But whenever age progresses, okay, with increasing age, closing capacity increases. So closing capacity increases with ages, and at 66 years of ages, closing capacity is almost equal to the functional residual capacity. So closing capacity is becoming, or closing capacity is equal to the FRC means the closure of the basal alveoli is early. Okay, early, more early closure of the basal alveoli means closing capacity will increase. That means in old age, lung become highly collapsible or easily collapsible or more collapsible. That's why whenever in old age, the person will start the forceful expiration, there will be closure of the basal alveoli first. And whenever the basal alveoli are closed off, then that is the closing capacity. And after that, the other alveoli will also get closed off. That's why residual volume, okay, will also increase, and closing capacity will also increase, and closing capacity will be almost equal to the functional residual capacity. Now, whenever you are getting that closing capacity is more than FRC, then it's a danger. That means the lung is very collapsible, highly collapsible, and you have to understand that the person is suffering from some small airways disease, which is highly collapsible disease, like for example emphysema and all. So whenever the person is suffering from small airways disease, the lung become highly collapsible, and in that cases the closing capacity may be greater than FRC also. So this is the concept of your closing capacity and closing volume. I told you again, I told you already that closing capacity and closing volume, can you measure with the help of spirometer? Answer is no. So how we are going to measure this? By single breath nitrogen washout method, by single breath nitrogen washout method. Okay, so single breath nitrogen washout method is the method by which we can measure the closing capacity and closing volume. Okay, so this is all about the static lung volumes and capacities. Now, after understanding the static lung volumes and capacities, now we are going to discuss the dynamic lung volumes and capacities. So here we are going to discuss various lung volumes and capacities with respect to time, right? So that's why in x-axis, the time axis has been enlarged. Okay, so the x-axis, see here, the long x-axis is there, because now we are going to measure the time, and y-axis is same to same, that is the volume. So how the maneuver is done? Again the same thing. You ask the subject to do a normal inspiration, normal expiration, inspiration, expiration, first few normal breathing. Then you ask the subject to take a deep inspiration as maximum as possible. So the person will reach to the maximum inspiratory level, and the total amount of air which is present inside this lung at this position is known as the total lung capacity. Now you ask the subject to hold the breath for a little bit. So holding of breath means there will be a flat line. So after holding the breathing, now the subject has to expire. Now during dynamic lung volumes and capacities recording, you have to instruct the subject that during expiration, the expiration should be forcefully, okay, as well as it should be faster. Means the expiration should be as faster as possible and as forcefully as possible. So you have to instruct the subject clearly. Okay, so the subject nose is closed, he is listening to you, and you instruct that do a forceful expiration as faster as possible, as forcefully as possible. So whenever the person will expire, what will happen? The curve will move in the downward direction, and it will reach at the end. After this point, the person is not going to expire further. So there will be few breathe, and then there will be stopping of the maneuver. Why the person is not able to expire after this point? Because we all know that there is a point beyond which you cannot expire, and the remaining volume in this condition is residual volume, that is there. Okay, so now I hope you understood that whenever the person is doing a forceful expiration, the curve is going in the downward direction, but because the person is doing the forcefully as well as faster, so the curve is going in the downward direction, and we have to measure the time. So the curve is a little bit spread. We have to actually increase the velocity of the drum, moving drum. So if you increase the velocity of the moving drum, so the graph will be easily spread out, right? Now I have to measure the dynamic lung volumes and capacity. So how to measure? Look at this. First of all, you have to identify the starting point of this expiration. So first of all, I have to identify the starting point of the expiration. So from this, I can easily understand that this is the starting point of the expiration. Okay. So from the starting point of the expiration, I am going to plot one perpendicular. I am to drop one perpendicular from the starting point on this x-axis. Okay. So the perpendicular is dropped. Okay. Now I have to find out what is the ending point of the expiration, ending point of expiration. So I can find out here that this is the ending point of expiration. Now from the ending point of expiration, I have to drop one perpendicular on y axis. So now again I am dropping one perpendicular. So this perpendicular is going towards the y axis. Okay. So this is the perpendicular. So now from these two perpendicular, I can find out that these two perpendicular are cutting with one another at a point. So this is the point where these two perpendicular are cutting. That means this is the point where the maneuver is started. So I am wiping out the other part. So I am finding out that this is the point where the maneuver has been started, right? And the ending point of the maneuver we have already identified. Now, so this x-axis from the beginning point up to the ending point, this x-axis, what is this? This is nothing but time. Time means what is the total time the subject has taken for this forceful and complete expiration, right? Okay. So, how much time is required normally? If I ask you take a deep inspiration and then you do a forceful expiration as much as possible, okay. So you do a forceful expiration. How much time you require? 1 second? Is it possible? No. Within 1 second, you cannot expire your lung fully. Okay. So at least 3 seconds is required. Normally, it is said that 3 to 6 seconds is required for the forceful and complete expiration of all the air from the lung. Right. So suppose in this maneuver, the subject has taken 3 seconds. So 3 seconds means we are dividing this long distance total time into 3 seconds. So this is 1 second, this is 2 seconds, this is 3 seconds. Okay. So I'll put 3 point here. So this is 1 second, this is 2 seconds. So this is 0, this is 1, this is 2, and this is 3 seconds. So we are assuming that the person has completed this maneuver within 3 seconds. Now, after completion of the maneuver, if I want to measure that what is the total volume of air the subject has expired, what I will do? Total volume of air the subject has expired. Okay. So basically, I have to drop on perpendicular from the beginning point of the maneuver on y axis. So this is a perpendicular on y axis. Okay. So I'll tell you, just look at this. Okay. So from this beginning point of the maneuver, I'm dropping on perpendicular. Okay. So this perpendicular is going on the y axis direction. So now from this beginning, okay, from this beginning up to end of this maneuver, if I calculate that what is the total volume, how the volume will be calculated? The volume will be calculated from the y axis, because in y axis there will be level, there will be multiple marking. Okay. So with the help of this y axis volume, if I measure the total volume of air that has been expired by this subject from the beginning and up to the ending, then this volume is known as the force vital capacity of this person. So what I say? FVC. FVC is the forced vital capacity. Forced vital capacity. So the volume will be equal to the normal vital capacity only, because it's a vital capacity. Okay. Because if I ask you take a deep inspiration and do a forceful expiration, how much volume of air you can expire? That is the vital capacity. Okay. So here also you are expiring the same volume, that is nothing but the vital capacity, but because the maneuver is a little bit different, we are calculating the time also, we are calculating the force, we are calculating the time also. So that's why here the forced word is used, because we are asking the subject to do forceful expiration as rapidly as possible, as forcefully as possible. So that's why the name is a little bit changed, that is the forced vital capacity. Now I want to understand that within this total force vital capacity, how much volume has been expired by the subject within 1 second, within 1 second. Okay. So, this is the beginning point of the maneuver, that is a 0 time point. From the 0 time point, if I go up to the level of this 1 second time point, how much volume has been expired? So, how can I do that? Very simple, pretty simple. From this 1 second point, I will drop one perpendicular on this curve. So, I will drop one perpendicular on this curve from this 1 second point. So, this is the perpendicular, okay, which is cutting this blue color curve. So, whenever I got this cutting point, okay, this is the point, okay. So, from the beginning point of the maneuver up to this cutting point, I have to measure the volume. Means what I am going to do? I am going to measure the volume from the beginning up to this 1 second point. If I measure this volume, then this will be known as the volume expired by the subject within 1 second. This is known as FEV1. What is FEV1? Forced expiratory volume. FE, forced expiratory volume. 1 means within 1 second. So, forced expiratory volume in 1 second. FEV1 is the forced expiratory volume in 1 second. Getting my point? So, normally within 1 second, the normal person will be able to expire 80% of the total volume. Means I can say like this, that FEV1 is generally 80% of the total volume that can be expired. What is the total volume? That is the FVC. So, I can say like this, that FEV1 is equal to almost 80% of the total volume that can be expired. So, obviously, I can take a ratio between this FEV1 upon FVC, and this is very important ratio. So, this ratio is 80%, and the name of this ratio is TIFFENEAU, Tiffenau ratio. So, this ratio is known as the Tiffenau ratio. What is the ratio? The ratio is the FEV1 upon FVC. So, if you take FEV1 upon FVC ratio, normally this ratio is 80%, and this ratio is known as the Tiffenau ratio, right. Now, if I want to calculate that what is the volume expired by this subject within 2 seconds, so the same thing I am going to do, that from this 2 second point I am going to drop an perpendicular here, and if I measure the total volume from the beginning up to this point, from the beginning up to this 2 second point, then this volume will be known as the FEV2. This will be known as the FEV2, and in these cases the FEV3 will be equal to the FVC, okay, because at 3 second point the volume which is expired, that is the total volume. So, this FEV2 normally, this FEV2 is normally 95% of the FVC, and this FEV3 is almost equal to the 99 to 100%. Okay, I should write down 99 to 100% of FVC. Getting my point? So, this thing you have to remember very carefully. So, this is known as the dynamic lung volumes and dynamic lung capacities. So, this FEV1 is a volume, okay, and this FVC is also a volume, but generally we measure both FEV1 and FVC with respect to time, okay, that within 1 second how much volume is expired. So, that is why they are known as the dynamic lung volumes and capacities. Getting my point? Okay. So, dynamic lung volumes and capacities is also measured with the help of spirometer, but here you have to measure the time in the x-axis, and with respect to time you are measuring different volume, FEV1, FVC, FEV2, okay, FVC, FEV3, okay. So, that is why this is very important to understand, okay. Now, after understanding the dynamic lung volumes and static lung volumes, we have to now enter into the different types of respiratory diseases, okay, how these diseases can be classified with the help of these lung volumes and capacities, okay. So, majorly two types of diseases are there in the respiratory system. One is obstructive and one is restrictive. So, I remember like this, that obstructive disease means it is the obstruction during the expiration of process, expiration, and restrictive disease means restriction during inspiration. So, obstructive disease means there will be airways obstruction, and this obstruction is going to happen mainly in which phase? During expiration. So, the obstruction is mainly going to happen during expiration, And restrictive disease means there will be restriction in inspiration. So, there will be restriction mainly during which phase of respiration? Restriction mainly during inspiratory phase. Inspiratory phase, right. Now, under this obstructive disease, there are certain important diseases like emphysema, chronic bronchitis, asthma and cystic fibrosis. But mainly we are going to understand the obstructive disease with the help of emphysema, right. That is a typical obstructive disease. And restrictive disease, whenever we say restriction, means if I try to take an inspiration, there will be certain restriction in my lung. So, this restriction can appear due to problem at the level of parenchyma, that is the lung parenchyma, or the restriction can also happen if there is certain problem in the thoracic wall or the bony cage. Okay. So, suppose there is a problem in the bony cage, then also you will not be able to expand your thoracic cavity, right. So, that is also one restriction of the inspiration. And if there is certain problem in the lung parenchyma, suppose lung parenchyma become harder, stiffer, then that is also restriction. So, parenchymal restriction and extra parenchymal restriction, any structure which is beyond the parenchyma, then that is known as the extra parenchymal. So, parenchymal restriction, the typical example is lung fibrosis, interstitial lung disease, lung fibrosis. And extra parenchymal restriction, it can appear due to problem in the bone, it can appear due to problem in the muscle. So, obesity, okay, that is deposition of the fat, or it can happen due to problem in the paralysis of the muscle, like for example, myasthenia gravis. Okay. So, kyphosis, scoliosis, bony problem, ankylosing spondylitis. So, these are the conditions where lung will not be able to expand fully during inspiration. Okay. During your huge obesity, if the obesity is very severe, morbid obesity, then also you will not be able to take deep inspiration. Okay. That is restrictive disease. Myasthenia gravis, muscle paralysis. So, this is the classification of the obstructive and restrictive disease. Now, if you want to understand the lung volumes and capacities, how they are going to change in the obstructive and restrictive disease, then first of all you have to understand one important phenomena which is known as dynamic compression of airways. Dynamic compression of airways. So, we have already understood the dynamic compression of airways little bit during the discussion of the closing volume and closing capacities. But further, we are going to discuss the phenomena once again here. So, try to understand what is the meaning of dynamic compression of airways. So, suppose this is the representation of the lung alveoli, okay, with bronchioles, okay, and this lung is situated within the thoracic cavity. Okay. So, this is the visceral pleura, parietal pleura, and above the visceral pleura, parietal pleura, there will be chest wall. Okay. So, during expiration process, if I do a forceful expiration, forceful expiration, after taking a deep inspiration, what is going to happen inside my lung, that we are going to understand here. So, suppose I have taken a deep inspiration. So, my alveoli are fully expanded. Now, after the end of deep inspiration, what happens? Because the alveoli are fully expanded, so the elastic tissue which was there surrounding this alveoli, they now will try to recoil back, right. So, whenever your alveoli are expanding, the elastic tissue which is surrounding the alveoli, they will try to recoil back, means there will be a tendency of elastic recoiling. So, suppose this elastic recoiling force, elastic recoiling force is equal to 5 millimeter of mercury. So, it is a force, na? Elastic tissue is trying to recoil. So, it is a force. So, how much force? Suppose we are assuming that the elastic recoiling force is 5 millimeter of mercury in these cases. Okay. And the subject is also doing forceful expiration. So, I told you already that forceful expiration means the subject has to apply some external force from the thoracic wall. So, the subject is applying external force from the thoracic wall. So, this is the chest wall force, chest wall force. So, suppose the chest wall force which is applied by the subject in this condition is 25 millimeter of mercury. Okay. So, during expiration, the subject is applying a external force from the thoracic wall, that is 25 millimeter of mercury, and the elastic recoiling force is also helping in expiration, and that force is 5 millimeter of mercury. So, what will be the total amount of force that will be exerted on the surface of the alveoli? If I ask you what will be the total amount of force that will be exerted on the surface of the alveoli, so 25 plus 5, so that is 30 millimeter of mercury. So, this is the total amount of force that will be applied on the surface of the alveoli. So, this 30 millimeter of mercury force means this alveolar pressure is very huge. Alveolar air pressure is very huge in comparison to the atmospheric air pressure, because atmospheric air pressure is 760 millimeter of mercury, that is equal to 0, because we already discussed that in respiratory system all the pressure is described in terms of relative pressure. So, as if your atmospheric pressure is 0 millimeter of mercury, and in that 0 millimeter of mercury atmospheric pressure, your alveolar pressure is now 30 millimeter of mercury. So, huge pressure. So, if the alveolar pressure is high, so what will happen? The air will go out of the alveoli. Okay, that is normal phenomenon. So, during expiration, the air is going out of the alveoli. So, more the air is going out of the alveoli, there will be decrease in the size of the alveoli. So, more you expire, there will be gradual decrease in the size of the alveoli, like this. And if you continue this expiration, so suppose I am continuing this expiration, forceful expiration, I am continuing. So, what will happen? At the end of the expiration, the alveolar size will be very small. Alveolar size will be very small. Okay, and this alveolar surrounded by the lung tissue, same diagram. Now, when the alveolar size is very small, what do you think? This elastic tissue, this elastic recoiling force will be higher or smaller in this condition? So, in this condition, the elastic recoil force will be very lesser, because the alveoli is recoiling back towards the original position. So, suppose in this condition, the elastic recoiling force is only 1 millimeter of mercury, reduced to 1 millimeter from 5 to 1, and you are maintaining the external force from the chest wall. And how much external chest wall force? Okay, so this is chest wall force, you are still maintaining the same amount of chest wall force, that is 25. So, in this condition, you are applying 25 pressure from chest wall, and one pressure is the elastic recoiling pressure. So, what is the total pressure inside this alveoli? That is 26 millimeter of mercury. So, with this 26 millimeter of mercury, what will happen? The air will still try to go out of this lung, but whenever the air is trying to go out of this lung, what will happen? This pressure will gradually reduce. Why the pressure will reduce? Suppose the pressure is 26 here, the pressure will gradually reduce to 25 millimeter of mercury, then it will reduce to 24 millimeter of mercury, then 23 millimeter of mercury. So, this way there will be continuous reduction of pressure. Tell me why? Why the pressure is reduced when the air is going through the airways? Because of the airways resistance. So, with this 26 pressure, the alveoli is trying to push the air out of this alveoli, and whenever this 26 pressure air is going through the bronchi and bronchiole, because of the resistance of the airways, this pressure will drop constantly. So, first there will be dropping of pressure from 26. So, if I write down here, okay, so suppose this is 26, okay, constantly it will drop 25, 24, 23, this way the pressure will continuously drop towards the mouth. So, I can understand that in this condition the person is applying an external force of 25 millimeter of mercury, and if you look at the force inside these bronchioles, that force or that pressure is how much? 25 millimeter of mercury, means the pressure which is exerted by this chest wall, that is outside pressure, that is same to same with the pressure inside this bronchiole. So, this condition where the inter bronchiolar pressure is equal to the outside chest wall pressure, this is the point which is known as the equal pressure point. So, this is known as the equal pressure point. Okay. Now, beyond this equal pressure point, what is happening? The bronchial pressure. So, beyond this point, what is happening? This bronchial pressure is lesser than that of this chest wall pressure. Getting my point? So, whenever this is happening, that this intrabronchial pressure is lesser than that of the outside thoracic wall pressure, there will be collapse of the bronchioles at this area. There will be collapse of the bronchiole at this area. So, there will be collapse here. and this collapse of the bronchioles, this phenomena is known as the dynamic compression of the airways. Okay, so try to understand. So previously also we have discussed that if you go on forcefully compressing your lung more and more, if you go on forcefully compressing your lung more and more, what will happen? Ultimately, one point will reach the alveoli is still open, but the bronchioles are closed off. So this constant compression on the bronchioles and ultimately the closure of this bronchiole, this phenomena is known as dynamic compression of airways. So there is constant compression of the airways during forceful expiration. One point is reaching where the bronchioles is closed, okay, and the point where the bronchiolar pressure is equal to the outside pressure, that is known as the equal pressure point. Beyond this equal pressure point, there will be collapse of these bronchioles. So this is a normal phenomenon that there will be closure of the bronchioles, there will be collapse of the bronchiole at the end of forceful expiration. How this normal phenomena? So this is a normal phenomena. This is a normal phenomena. Okay, how this normal phenomena is different in case of obstructive disease or in case of emphysema. Now that we are going to understand that. So in case of emphysema, we know that the alveoli is hugely expanded. Okay, so alveoli is hugely expanded, and because of the huge expansion of the alveoli, what happens in the lung? Some of the alveoli get ruptured. So whenever the alveoli is getting ruptured, what will happen to the elastic tissue which is surrounding them? So obviously the elastic tissue will also get ruptured. Okay, so this thing we have discussed multiple times that in case of emphysema there will be rupture of the sum of the alveoli, rupture of the sum of the alveoli. Whenever there is rupture of the sum of the alveoli, so what will happen to the elastic tissue? Elastic tissue is damaged. So I am also writing here that in case of emphysema, the elastic tissue which is surrounding the lung, they are damaged. Now whenever the elastic tissue surrounding the lungs are damaged, then I can understand the lungs will be easily expansile, because the elastic tissue, they will try to prevent your expansion of the lung. There is an opposing force for your expansion of the lung. So whenever the elastic tissue is damaged, I can say that the compliance of the lung in emphysema, okay, compliance chapter is separately there, compliance will be increased. Compliance increase means lung is easily expansile. Now if the lung is easily expansile, so what will happen if the person, if the emphysema patient try to take inspiration? Okay, so inspiration will be difficult or inspiration will be easy? Inspiration will be easy. Why? Because the lung compliance is high. Lung compliance high means lung is easily expansile. So whenever the person will take inspiration, the lung will be fully expanded, or the expansion may be a little more than that of the normal person also. So there will be hugely expansion of this alveoli. So there is no problem. Inspiration is easy. But now when the person will try to do expiration, normally in our lung, expiration is a passive process. Why? Because the elastic tissue which surround the alveoli, those elastic tissue recoil is sufficient to compress the alveoli to the original condition. But in case of emphysema, because these elastic tissues are destroyed, so what will happen to the elastic recoiling force? The elastic recoiling force will be near equal to 0 millimeter of mercury because of the rupture of this elastic tissue, because of the rupture of this elastic tissue, because of the damage of this elastic tissue. So now if the elastic recoiling is not there, how the person will able to do expiration? So the person will able to do expiration by applying external force from the chest wall. So now the person has to apply forces from chest wall. So chest wall force. Now whenever the person will apply force from the chest wall, so suppose in this cases also we are assuming that the person is giving a force from the chest wall, how much? That is 25. So this 25 external force, it will be exerted at the level of alveoli. So inside the alveoli, the total force will be 25 because elastic recoiling force is 0. And this 25 force is also going to be applied at the level of these bronchioles also. At the smaller size bronchiole, the external force is 25 millimeter of mercury. So now whenever this air will try to go out of this lung, whenever this air will try to go out of this lung, the pressure will drop. I told you already why the pressure is dropping, because of the resistance of the airway. And whenever there is a drop of pressure even a little bit, then you can find out here that intrabronchial pressure is lesser than that of the outside exerted pressure. So, what is going to happen? Immediately there will be closure of the bronchioles at the onset or at the early stage of expiration. So, what is happening? Whenever the person is trying to expire, so during expiration, what is happening? There is closure of bronchioles. Okay, so this closure was also happening in case of normal person also, but here the closure is very early closure, very early. You can say that even at the beginning of the expiration the closure can happen, and whenever at the beginning of the expiration the closure is happening, we can easily understand that huge amount of air is going to remain inside the alveoli. Why? Because during inspiration, because the inspiration was easier process, the subject has taken a deep inspiration, huge inspiration, and huge amount of air has entered inside the lung. But whenever the person is trying to expire, immediately there is closure of the bronchioles. So I can understand that huge amount of air is entering during inspiration, but that air is not able to go out of the lung during expiration easily. So there is more and more trapping of air inside the lung, and this is known as the air trapping phenomena. And whenever more and more air is trapped inside the lung, there is closure of the bronchioles, the air is trapped inside the lung, what will happen to the residual volume? The residual volume is going to increase. And if the residual volume is increasing gradually more and more and more, what will happen to the total lung capacity? The total lung capacity will also increase because of gradual increase in residual volume. So, getting my point. So, now you can correlate. Then in emphysema, why it is known as obstructive disease? Because there is obstruction. Obstruction also happen in our lung at the end of forceful expiration, but here whenever the person is trying to expire at the beginning of the expiration, the emphysema patient, there will be early closure of the smaller size bronchioles, and whenever there is early closure, the more air will be trapped inside the lung. So more air trapping, more expansion of the lung. More expansion means there will be more increase in TLC. So more and more expansion of the alveoli. So one point will reach where more number of alveoli is going to get ruptured. So that's why we say this is a kind of vicious cycle. Okay, whenever initial rupture is there, this initial rupture means elastic tissue is destroyed. Elastic tissue destroyed means more air trapping. More air trapping means more increase in TLC. More increase in TLC means more expansion of alveoli, more rupture. So this way the vicious cycle will continue, and emphysema patient will suffer from severe obstruction of the smaller airways during the expiration process. Got it? Okay, so now you got it. So now we look at whenever your TLC is increasing more and more in case of emphysema patient, the thoracic cavity has to accommodate that extra TLC. So your lung is expanding. So if the lung is expanding more and more, normally our anteroposterior diameter of the thoracic cavity is little lesser. So look at here. So this is the cross section of the thoracic cavity. So we can find out here that the anteroposterior diameter, so this is the AP diameter, is lesser than that of the lateral diameter. But if your lung is expanding more and more because of the increase in TLC, okay, because of the increase in TLC, okay, so you have to accommodate this extra volume of air within your lung, within your thoracic cavity. So what is going to happen? There will be expansion of the anteroposterior diameter of the thoracic wall. And whenever the anteroposterior diameter is enlarging more and more, so the lateral diameter and anteroposterior diameter is almost becoming equal with one another. And whenever this is equal with one another, this is known as the barrel shaped chest. So this is a typical deformity in case of emphysema, in case of chronic emphysema patient, because of the gradual increase in TLC. Okay. Now, emphysema patient, if the person is suffering from emphysema chronically for long duration, then there is a particular pattern of breathing in the emphysema patient, and that particular pattern of breathing is known as the pursed lip breathing. Okay. So pursed lip breathing means the person will take normal inspiration. So the inspiration is normal and easy. But during expiration, the person will expire like this. So what he is doing? He is just closing his lips, almost closed, and then he is trying to gather pressure inside the mouth cavity. So I am accumulating pressure inside my mouth cavity. If I increase the pressure inside my mouth cavity, what is going to happen? This closure which is going to happen here, this closure will be prevented. Why the closure will be prevented? Because now you are giving some extra pressure from mouth. So this mouth pressure will go in the backward direction, and this mouth pressure will try to expand these bronchioles which is supposed to get collapsed. So that's why whenever the person is doing this pursed lip breathing, so this mouth pressure is basically transmitting back into the lung, and it is trying to opening up, or it is trying to keeping this small size bronchiole open in open condition so that it is not getting early collapsed. So this way, this pursed lip breathing is helpful for expiration for a longer duration. It will prevent the early closure of the bronchioles in emphysema patient, and this is known as pursed lip breathing. So during expiration, the person is expiring but with some force inside the mouth cavity. So this kind of breathing is known as the pursed lip breathing. Got it? Now, if you try to understand the restrictive disease pathology, this is very easy to understand. Why? Because restrictive disease means, I told you that suppose this is an alveoli, okay, the restriction can happen within the parenchymal region. So suppose outside this alveoli there is lung interstitial tissue. Now this lung interstitial tissue contain elastic tissue, we have already discussed in emphysema patient also. Now suppose this elastic tissue is replaced by fibrous tissue here. So the elastic tissue is replaced by fibrous tissue, that means there is fibrosis. So whenever there is fibrosis, the lung will be harder, that means there will be increased stiffness of the lung. Now, whenever there is increased stiffness of the lung, we can say what will happen to the compliance of the lung? That the compliance of the lung will decrease, means lung will not be easily expansile. So, in these cases, the fibrotic tissue will not allow the lung to expand fully during inspiration. So, whenever the person will try to take one inspiration, the inspiration will be difficult. The inspiration will be difficult. Okay, it will not be able to, the person will not be able to expand the lung fully. So, inspiration is difficult, restriction is happening during inspiration. Now, if the person is having difficulty in full inspiration, so what will happen to the TLC, total lung capacity? Obviously, the total lung capacity must has to be reduced. Not only that, the residual volume can also reduced in this condition. Got it? So, this is typical of parenchymal restriction. But you also know that the restriction can also happen from this thoracic cavity or from the chest wall. So, suppose this chest wall is hard, okay. Suppose this chest wall is deformed, the chest wall is stiff, there is ankylosing spondylitis, there is kyphocoliosis, or suppose the muscle is paralyzed. So, in this condition also, the inspiration is going to be restricted, because whenever you will try to take a deep inspiration, there will be restriction. But note down that if your chest wall is, suppose the muscles in the chest wall is paralyzed. So, in this condition, if I ask you that do a forceful expiration, will you be able to apply maximum force in this condition? Answer is no, because your muscles are paralyzed. So, if you are not applying maximum force, then you are not expiring fully from the lung. So, what will happen to the residual volume in these cases? In these cases, the residual volume may increase. So, that's why please note down that residual volume may be decrease in case of restrictive disease, may be increase. If the restriction is parenchymal restriction, TLC decreases and residual volume both decreases. But if the restriction is extraparenchymal, then the TLC is definitely going to be reduced, but residual volume will increase a little. Okay, so this is the concept of restrictive and obstructive disease. Now, after understanding the concept, if you look at the dynamic lung volumes and capacities, that how the dynamic lung volumes and capacities is going to change in case of restrictive disease, because static lung volumes and capacity we have already seen, TLC, residual volume we have seen. Now, how the dynamic lung volumes and capacity is going to change? So, first you look at this normal curve. We have already seen this dynamic lung volumes and capacities recording curve. So, only the expiratory portion of the curve is given. So, this is the expiratory portion of this curve, normal curve. Okay. So, I hope you are understanding that this is the beginning point of the maneuver and this is the ending point of the maneuver. So, from the beginning point up to the ending point, if you measure the total volume, what is the name of that volume? That is known as the FVC, force vital capacity. So, this is FVC, and within this FVC, if you measure the volume within 1 second, then that is FEV1 1 second. So normally the FEV, that is the forced expiratory volume in 1 second, is normally 4 liter, and forced vital capacity normally it is 5 liter. So if you take a ratio, that is 80%. Okay. Now you try to think of that if you do the same maneuver, dynamic lung volume and capacities you want to measure from an emphysema patient. So there will be early closure of the airways. So whenever the closure of the airways is early, then the expiration will not be rapid like this. Expiration is not going to be normal like this. So now you try to compare with the normal person. So normal person, if you ask do forceful expiration, so the expiration is going like this. This is the normal. This is the normal. But if you compare with the normal person, in case of emphysema, as you can find out here clearly, that the expiration is slowly going for long duration, and even after end of expiration, the person is not able to expire fully. That means what will happen to the residual volume? The residual volume will increase. That means in the dynamic lung volumes and capacities graph, if you are getting a flat curve which is continuing for long duration, you are understanding that the closure is happening, closure is going to happen. So that means bronchioles are getting closed. So this is typical of the obstructive disease. And in case of restrictive disease, okay, so if you compare with the normal curve, so the normal curve will look like this, normal curve will look like this. Okay, if you compare with the normal curve, restrictive disease curve is very fast, because whenever your lungs are stiff, whenever your lungs are harder, it is very difficult to expand the lung. But after expansion, if you allow the lung to recoil back, it will recoil with huge amount of force. It will recoil rapidly. That is a normal phenomenon. If the structure is hard, it is very difficult to deform. But whenever after deforming, if you allow it to recoil, it will recoil with higher force. This is like a normal spring. Spring, if it is hard, so it is very difficult to expand. But easily chhod do, so it will recoil back easily. Getting my point? So the exact thing is happening here, that in case of restrictive disease, the expiration is easy, expiration is rapid, even it is faster than that of the normal person also. So in restrictive disease, the expiration is faster, so he may take smaller time than that of the normal person also. So normal person may take 3 seconds, but in case of restrictive disease, he may take 2 or 2 seconds maybe. Okay. So if we measure the FEV1, FVC from this obstructive disease patient and restrictive disease patient. Suppose we are measuring this FEV1 and FVC from obstructive and restrictive disease patient. What you are finding out? Okay. So first you look at this obstructive disease. Okay. B. So in obstructive disease, I am finding out that this FEV1 is changed from 4 liter to 1.3 liter. That means there is reduction in the FEV1. And FVC has also reduced, it has been reduced from 5 liter to 3.1 liter. So now if I ask you that in case of emphysema, in case of obstructive disease, what happens to FEV1? Reduces. What happens to FVC? It also reduces. So please note down, both are the volume. FEV1, it is also a volume, okay, and FVC, it is also a volume. So in case of obstructive disease, FEV1, it is reduced, and FVC, it is also reduced. But now if I look at the reduction amount, so I can easily find out that it has reduced from 4 liter to only 1.3 liter, very severe reduction. But it has been reduced from 5 liter to 3.1 liter. Reduction is there, but that reduction is not severe. Means if I take this ratio, that is the T-Phenol ratio, FEV1 upon FVC, then I am finding out that FEV1 is also reduced, FVC is also reduced, but which one has been reduced much more? FEV1. So in this ratio, the numerator of the ratio has been reduced to a very low level in comparison to the denominator. So what will happen to the ratio? The ratio also reduces. That's why in case of obstructive disease, the FEV1 FVC ratio is reduced. Got it. Now if you look at the restrictive disease, okay, so restrictive disease, so now I am finding out the value. So FEV1 has been reduced from 4 liter to 2.8 liter. There is reduction, there is definite reduction, but from 4 liter it has reduced to 2.8 liter. But if I look at the FVC, FVC has reduced from 5 liter to 3.1 liter. So, which reduction is more? In case of restrictive disease, I can find out easily from here that there is definite reduction in FEV1 volume also, and there is definite reduction in FVC volume also. But if I take a ratio, I can easily find out that FEV1 is also reduced, FVC is also reduced, but FVC has reduced to a very low level. So, in our ratio, if the denominator of the ratio is reduced to a very high level, then what will happen to the ratio? The ratio increases. So, that is why we know that in case of restrictive disease, in case of particularly the parenchymal restrictive disease, the ratio FEV1 FVC ratio increases. Got it? So, this is the concept that you have to remember, and after understanding this concept, now you look at the difference between obstructive disease and restrictive disease. So, typical examples of the obstructive disease, that is the emphysema and asthma has been given here, and the typical examples of the parenchymal restriction lung fibrosis is given, and typical example of extraparenchymal restriction myasthenia gravis is given. Now, you assume that normal value is 100%. So, in this graph normal value is 100%. So, what will happen to the total lung capacity in case of restrictive and obstructive disease? So, obstructive disease, there will be definite increase in TLC, particularly in emphysema. In case of asthma, it may be normal, okay, but there must be reduction in the total lung capacity. So, from 100% it has reduced to 60%, from 100% it has reduced to 75%. So, this reduction of the TLC is one of the definite feature of the restrictive disease. It has to happen, otherwise it is not a restrictive disease. Getting my point? But TLC will be increased typically in obstructive disease, but it may not be increased in early stage of asthma, like for example here. Okay. Now, what about residual volume? The residual volume is the parameter which must has to be increased in obstructive disease. So, again, this is one of the feature which has to be present in case of obstructive disease. Without increment of the residual volume, it is not obstructive disease. Okay, and what will happen to the residual volume in restrictive disease? It may increase. I have shown you already that extraparenchymal restriction means there will be increase in residual volume, but parenchymal restriction means there will be decrease in the residual volume. Then what will happen to the FEV1 and FVC? We have discussed multiple times that FEV1 as a volume is reduced in all types of disease, restrictive disease, obstructive disease, in all. There will be reduction in FEV1 volume. And FVC volume, FVC is also going to be reduced in all the diseases, all diseases. But now you look at the trend of this reduction. Okay, trend of this reduction, we have already discussed that in case of obstructive disease, FEV1 reduced much more than that of the FVC. Okay, so FEV1 has reduced from 100% to 35%, but FVC has reduced to 100% from 100% to 60%. So, which one has reduced more? This has been reduced more. But in case of restrictive disease, see here, this has reduced from 100% to 75%, and it has reduced to from 100% to 60%. Which has been reduced? The FVC has been reduced more. So, whenever the FVC is reduced more, there will be increase in ratio. But you are also finding out that in case of extraparenchymal, the reduction of the FEV1 and FVC both are almost equal. If the reduction is almost equal, then the ratio may be normal also. So, that is why this ratio may be increased in restrictive disease, it may be normal. So, this is not a diagnostic feature. If it is normal, then it may be on restrictive disease also, but you have to look at the other parameter, whether it is restrictive disease or not. But if the ratio is reduced to a very low level, 35%, 40%, which is normally how much percent? Normally it is, ratio is normally how much? I told you TFNM ratio normally is 80%. So, if this ratio is reduced to 30% or 40%, then you are absolutely sure that you are dealing a case of obstructive disease. The ratio will be reduced to a very low level. Got it? Okay. Now, this AR is the airway resistance. So, we have discussed that emphysema means there will be closure, there will be early closure of the airways, there will be collapse of the airways. So, resistance increases. So, 1.5 times than the normal. In case of asthma, because of the bronchospasm, the airway resistance is highly increased. Okay, so the resistance is more higher even than that of the emphysema also. In case of restrictive disease, the airway resistance remain normal. 1 means normal. And last one is the DLCO. DLCO is the diffusion capacity of the lung. Diffusion capacity of the lung is reduced in case of emphysema because of the rupture of the alveoli. Diffusion capacity is little increase in case of asthma because of the hyperinflation of the lung, because of the hyperinflation of the lung. Okay, and why it is reduced in case of emphysema, because of the damaged of alveoli, because of the damaged of alveoli. And this is definitely going to be reduced in case of restrictive disease, because if there is parenchymal restriction, so fibrosis is there. So fibrosis means membrane is thicker, and if there is extra parenchymal restriction, because you are not taking adequate amount of inspiration, so the volume of air which is coming in your lung is less. So that's why the diffusion capacity reduces in restrictive disease. Got it? So this is the difference between these two. Now, after understanding all of this thing, we are going to look at the digital spirometer. So far we have discussed the normal spirometer, where the air drum was there inside a water jacket. But in digital spirometer, all this thing arrangement is not there. There will be a computer screen, and there will be a small mouthpiece, and in that mouthpiece the sensor will be there. So in this diagram, as you can find out here, this is the mouthpiece. So after closing the nose of the subject, you just ask the subject to do a forceful inspiration, normal inspiration expiration, followed by a forceful expiration inside this mouthpiece. This mouthpiece contains sensor. So the sensor will detect the changes in the volume of the air, and it will be recorded on this machine, right? So this is the simple maneuver, very simple maneuver. Now with this digital spirometer, what we are going to record? The same thing we are going to record, but the recording will look a little different. That's why you have to look at that in digital spirometer, how the recording looks like. Okay. So first of all, I will show you the normal spirometer, normal spirometer recording, and along with that we are going to discuss the digital spirometer recording. So normal spirometer recording, we have already seen the normal inspiration expiration, then you take a deep inspiration, then you do a forceful expiration, and it will look like this, right? So suppose I am putting some number here. Suppose this is A, this is the middle part of the expiration is B, and end of the expiration is C. In digital spirometer, only the expiratory portion is recorded. So one recording you will see where y-axis is volume, but this y-axis is recording which volume? The expiratory volume is going to be recorded in y-axis. So the inspiration, this inspiration, expiration is not going to be draw here. Only this expiratory curve is going to be recorded in the digital spirometer. So whenever the person is starting the expiration, it will start from this point, that is a 0 point, that is the starting point. So this point, from here the maneuver will be started, the expiratory maneuver. And then when the person is doing this forceful expiration, the curve will go like this, go like this, go like this, go like this, and then this is the end of the maneuver. So x-axis is what? X-axis is same time. I told you that during forceful expiration, how much time is required to complete the expiration? At least 3 seconds, maybe 3 to 6 seconds. So in this digital spirometer, if I put this A, B and C point, so this will be A point, this will be more or less B point, and this is the end point, that is the C point. So please try to compare that. If this is the beginning point of the expiration in normal spirometer, then this is the beginning point of expiration in digital spirometer, and C is the ending point of expiration in digital spirometer, and here also C is the ending point of expiration. So the x-axis is time. So suppose this x-axis time is divided into multiple parts. So suppose this is 1 second point, this is 2 second point, this is 3 second point, this is 4 second point. So suppose in these cases the person has expired within 4.5 seconds. Now in this digital spirometer recording, if I want to calculate what is the volume of FEV1, what I am going to do, this will be very, very simple. That's why the digital recording is there. So I have to just drop on perpendicular from this 1 second point. Okay. So where the perpendicular I am going to draw, I am going to drop this perpendicular on this expiratory curve, and from there I am going to drop another perpendicular. So this, from this junction I am going to drop another perpendicular on y-axis. Now if I look at the value on this y-axis, then this is the value which is known as FEV1. Getting my point? So this volume which you are getting at y-axis, this is your FEV1 volume. And if you measure the total volume from the beginning point up to the end point, then what will be the name of this volume from the beginning point up to the end point? This is nothing but your FVC, force vital capacity. So from the digital spirometer recording, easily you can calculate FVC, easily you can calculate FEV1, and then you calculate the Tiffenau ratio. Okay. Now, if you calculate the slope of this curve, then this is known as the peak expiratory flow rate. So, if I measure the slope of this curve, okay, so what is the slope of this curve? Suppose I have calculated the slope. The slope of this curve is known as the peak expiratory flow rate. Okay. So, what is the maximum flow rate during this expiration? That is known as the peak expiratory flow rate. How to measure the peak expiratory flow rate from this maneuver? Do a slope. Okay. The maximum slope of this curve will give you the peak expiratory flow rate. Got it? So, this is the digital spirometer recording. Now, in digital spirometer recording, there is another recording is also there. So, in one side of the computer screen, you will get this kind of recording, and in other side of the computer screen, you are going to get a flow volume loop recording. There are other kind of system also where normal recording, just a recording is also there, but normally most of the digital spirometer, in one side the recording that we have already discussed, that will be shown, and on the other side this flow volume loop will be shown. Now, in flow volume loop, the recording is a little different. Why it is different? You have to understand very carefully. So, flow and volume, x-axis is the volume, it is not the time, and y-axis is the flow. So, y-axis is the flow and x-axis is the volume. Time is not plotted in this x and y-axis. Now, here another difference is there. The x-axis, the marking of the x-axis will be start from your right hand side, means suppose this is 0, okay, then this is 1, this is 2, this kind of recording will be there like this. So, volume in liter, but this marking will be started from the right hand side. So, this is 0 volume suppose, and the volume will be increased towards your left hand side. Another one difference is that the recording, the inspiratory flow recording will be done in the downward direction. So, this downward direction recording is inspiratory recording, and upward direction recording will be the expiratory recording. If you ask me why so, sir, this is according to the calibration, according to the convention of the recording. The inspiratory recording will be in the downward direction. Okay, so below this x-axis, the inspiratory recording will be there, and above this x-axis, the expiratory recording will be there. Okay. Now, in this system, if you ask the subject to take a normal inspiration and expiration, so normal inspiration means the curve will look like this. What is the meaning of this curve? Everybody try to look at. So, if you take a normal inspiration, so your mouthpiece is there, and inside the mouthpiece you are taking normal inspiration. So, what will happen? The flow of air will increase, and then the flow of air will decrease, and then that is the end of inspiration. Very simple. So, whenever you take inspiration, the flow is going to increase, and then the flow is going to decrease, and that is the end of inspiration. Same way, if you do an expiration, so expiration flow will also increase gradually, and then the expiration flow will decrease, and again you are reaching here. So, this is the normal inspiration and expiration. So, during inspiration the flow is rising, then ending. During expiration, flow is rising, then ending. This is normal. So, if I measure the volume of air during this normal inspiration and expiration, how I am going to measure? So, from this beginning point up to the ending point. So, what is x-axis? X-axis volume. So, if I measure this volume, what is the name of this volume? This volume is nothing but your tidal volume. So, the flow volume loop is also giving you the tidal volume recording. But for tidal volume recording, the flow volume is not plotted. There are other things. So, now we have to ask the subject to do a forceful inspiration as much as possible, as much as forcefully as possible. Okay. So, whenever the person will start a forceful inspiration, okay, so now the curve will go in more deeper direction. So, the inspiratory flow will rise more, then the flow is rising, then the flow will start decreasing, okay, then the flow will start decreasing gradually, and ultimately person will reach to a maximum volume point. So, getting my point. So, now you look at the curve. Now, whenever you are asking the subject to take a deep inspiration, the inspiratory flow is increasing to a very high level, and then the inspiratory flow is decreasing, and the person is reaching at the end of inspiration. So, at the end of forceful inspiration, At the end of the forceful inspiration, the total volume of air which will be present at this condition inside the lung, what will be the name of that? That will be known as the total lung capacity. Getting my point? So, if you measure the volume from 0 point up to this point, then this total volume which is present inside the lung, that is multiplication of multiple volume, that is addition of multiple volume, and that is total lung capacity. Okay. Then you ask the subject to do a forceful expiration. So, whenever the person will do a forceful expiration, immediately the flow rate will be very high and it will reach to a peak point. And after that peak point, the flow volume will reduce to a very low level and the person will reach at the end of expiration. So, look at now the flow is reduced and the person will reach at the end of expiration. So, if I ask you why the flow is suddenly start decreasing in this manner, that the flow is reducing to a very low level, flow is decreasing. Why? Because of the dynamic compression of the airways. We know that during expiration there will be gradual compression of the airways. So, initially when you have taken a deep inspiration, whenever you are here, you have taken a deep inspiration, your lung are fully expanded. Now, if you apply force from the thoracic wall, immediately there will be huge amount of air that will go out of the lung. That's why there will be huge amount of flow during expiration. But after that, now the airways will go for more and more compression. More and more compression means the flow will reduce and ultimately the person will reach at the end of expiration. So, now if I ask you that after the end of this forceful expiration, now the person is again asked to take a deep inspiration once again. So, now the person will take deep inspiration once again. So, deep inspiration, and again he will reach to the total lung capacity, and now it is forming a big loop, and this loop is known as the flow volume loop. So, now you look at, so now I am completing this loop. So, inspiration, inspiration, this is the end of inspiration, maximum inspiration, and then the person is doing expiration, flow rate decreasing, and the person is reaching at the end of forceful expiration. Okay. So, now if I ask you that even after the end of forceful expiration, the volume which is still remaining inside the lung, what is the name of this volume? This is nothing but your residual volume. So, from this 0 point, okay, if you measure the volume even after the end of forceful expiration, the volume which is still remaining inside the lung is residual volume. Got it? So, you got it, the tidal volume, you are getting the residual volume, and if you measure the volume from this TLC point up to this residual volume point, what is the name of this volume? Tell me. So, from this residual volume point up to the TLC point. So, if you remove the residual volume from the total lung capacity, what is the name of that? That is nothing but your force vital capacity. Getting my point? So, that's why whenever you are plotting this flow volume loop with the help of the flow volume loop, you are going to get this force vital capacity, you are going to get the tidal volume, you are also going to get the inspiratory reserve volume. Inspiratory reserve volume, what is that? Above this tidal volume, what is the extra amount of air that you are taking in? What is the extra amount of air that you are taking in? That is your inspiratory reserve volume. Expiratory reserve volume, this is the expiratory reserve volume. So, I can show you from here, but it will be more congested. So, this is my expiratory reserve volume and this is my inspiratory reserve volume. Getting my point? So, all the volume, static lung volumes that you have measured with the spirometer, all this thing can be calculated from this flow volume loop also. Getting my point? So, this flow volume loop has a particular shape, okay, and the expiratory portion is much more important for diagnosis of various respiratory diseases, okay. So, during expiration, there is a maximum flow and that is known as the PEFR, peak expiratory flow rate. We have already seen that in digital spirometer, if you take the slope from this curve, then also you are going to get the PEFR. The PEFR can also be calculated from the flow volume loop, okay. And peak inspiratory flow, if you take the maximum flow rate during inspiration, that is known as the peak inspiratory flow, okay. And look at the shape. So, inspiration is very smooth. Expiration is also smooth, but suddenly there is a rise followed by there is a sudden fall in the expiratory loop of this flow volume loop. Got it? Okay. Now, from the flow volume loop, another important thing you have to also understand, that is known as the maximum mid expiratory flow rate. So, what is that? So first of all, I am drawing a flow volume loop. Okay, normal deep inspiration followed by normal deep expiration. Okay, so this is the normal flow volume loop. So from this normal flow volume loop, we have already seen that if you measure the volume from this TLC point up to the residual volume point, then what is the name of this volume? This is known as the FVC, force vital capacity. You have already seen here force vital capacity. Okay, so the same force vital capacity I am showing you here. So now suppose force vital capacity, whatever is the volume, maybe 4 liter, maybe 5 liter, whatever. Normally it is 4 liter. So suppose this force vital capacity 4 liter. I am dividing this total volume into 4 division. So total volume FVC is suppose 100%. So I am dividing this into 4 division. So 25%, okay, then 50%, then 75%, and then 100%. Why in this ulta direction? Because the expiration has started from here, and if you are expiring more and more, then first of all you are expiring 25%, then 50% of the total volume, 75% of the total volume, 100% of the total volume. Now if I want to measure that what is the flow rate at the middle part of the expiration, flow rate at the middle part of the expiration. So the middle part means if you measure the flow rate between this 25 percentage to 75 percentage. So from this 25 percentage point to the 75 percentage point, within this zone, if I measure that what is the average flow rate, flow rate during this middle part, okay, not the average. If I take the maximum flow rate during this middle part of this, then that is known as the maximum mid expiratory flow rate. Got it? Why you are going to measure the maximum mid expiratory flow rate? Because this is a very sensitive indicator of small airways disease like emphysema. If there is a reduction of this MEFR value, then MMAFR value, then you are 100% sure that the small airways disease has been set in. So at the end stage of the disease, there will be multiple problems. But if you want to diagnose the disease at the early stage, then this is known as the very sensitive indicator of the small airways disease, early disease of the small airways. Got it? Okay. Now, this MMEF is also known as FEF 25 to 75%, FEF 25 to 75 percentage. Why? Look at what we are measuring. We are measuring what is the maximum flow rate from this 25 to 75% of the volume expiration. That is in the middle part. So you are doing a force expiratory flow rate calculation, from this 25% of the lung volume to 75% of the lung volume during expiration. And that's why this MMFER or maximum mid expiratory flow rate is also known as FEF 25 to 75%, and this is the new name, this FEF 25 to 75%. And I told you this is a very sensitive indicator of small airways diseases, Got it? Okay. So now I will show you the Book's diagram of this flow volume loop, okay, and the normal digital spirometer. So we have already seen this diagram. So this diagram was taken from Genong. So this is your FVC, this is your FEV1, okay, and this is the PV loop, flow volume loop. PV loop is in the cardiovascular system. So here, so this is the inspiration. More you do the forceful inspiration, more deeper the curve will go. That is showing here. So multiple inspiration, but more and more deep inspiration means the curve is going in the more and more deep direction. And during expiration, more the forceful expiration means the curve is going in the more upward direction. But look at here, the left hand side of this curve, it is written the effort dependent, means if you give more force from your thoracic wall, then you are going to increase this PEFR, that is the peak expiratory flow rate, will go on increasing more and more. So this peak expiratory flow rate or the left hand side of this curve, it depends on the force from the chest wall. But on the right hand side, okay, right hand side of this curve, there is almost a straight line decrement. There is almost a straight line decrement of this flow rate. Why? Because of the dynamic compression of the airways. And whenever there is compression of the airways, if the airways is getting compressed, then whatever may be your force from the chest wall, it is not going to increase your flow rate. That's why on the right hand side, this curve is known as the effort independent curve because of the dynamic compression of the airways, Getting my point? So this is very important thing to remember. Okay. Now this flow volume loop is used for diagnosis of obstructive and restrictive disease. How? Now look at here. What is this you are seeing here? So this x-axis is the lung volume, and I told you 0 is on your right hand side and maximum volume is on left hand side. And in what is y-axis? The y-axis is air flow. So this is flow volume loop. But typical, it is not showing the loop that we have seen, it is not shown here, because here in this diagram the inspiratory part has not been drawn. So if you drawn this inspiratory part, then the normal curve will look like this. So this inspiratory curve is not drawn here, only the expiratory curve, because mostly the diagnosis will be done from the expiratory portion. So first of all, you note down this normal curve. Okay, note down this normal curve. So after noting down this normal curve, so this yellow highlighted curve is a normal curve. If I look at the obstructive disease curve, how to understand that this is an obstructive disease curve? So look at here, peak expiratory flow rate. What has happened to the peak expiratory flow rate? So PEFR has been reduced. And if I look at the expiratory portion, then it is not sharply decreasing. There is a depression, that means small airways is getting collapsed. So if I look at this curve, then the curve will look like this. The flow volume loop will look like this. So the flow volume curve is showing that there is reduction in the PEFR, peak expiratory flow rate has been reduced, but there is increment in the TLC. The TLC has increased. And what has happened to the residual volume? The residual volume has also increased. Okay, because this is the residual volume point in this curve. Okay, so if the TLC is high, your residual volume is high, and your PEFR has been decreased, and there is a depression in the expiratory portion of the curve, mainly on the right hand side of the curve, then this is typical of obstructive disease. Okay, and in restrictive disease, look at this curve. So this curve is very narrow curve, very narrow curve. But what is happened to the PEFR? Again, in this cases also, PEFR, peak expiratory flow rate, has reduced. Okay, what has happened to the TLC? The TLC has also reduced. And what has happened to the residual volume? The residual volume has also reduced. So this is typical of parenchymal restriction. Parenchymal restriction, because I told you already that in case of parenchymal restriction, residual volume is also reduced. Okay, TLC is also reduced and PEFR is also reduced, and here the curve is narrow. Got it? So this is the typical shape of the obstructive and restrictive disease parenchymal restriction curve. But if you ask me that how the extraparenchymal restriction curve looks like, then you look at here. So first of all, you note down the normal curve from this diagram. So this black color, solid black color curve, this yellow highlighted curve, this is the normal curve. Now you try to understand the curve of the obstructive disease. So this is obstructive disease curve. O means obstructive disease curve. Generally, we say that in obstructive disease, this expiratory portion, there will be a depression in the expiratory portion, and this is typically known as scooping out of the expiratory portion. So this is typically known as scooped out in the expiratory portion of the curve. So scooping out of the expiratory portion of the curve. And we have also seen that in case of restrictive disease, if the parenchymal restriction is there, then the curve will be narrow and the residual volume will decrease. Now here you have to note down the extraparenchymal restriction. So this curve is the extraparenchymal curve, extraparenchymal restrictive disease curve. So the curve is narrow. So whether it is parenchymal restriction or extraparenchymal restriction, in both the cases, the flow volume loop will be very narrow. And in both the cases, the TLC will be reduced. But if the residual volume is higher than normal, then it is the typical of the extraparenchymal restriction. But if the residual volume is lower than normal, then that is the typical parenchymal restriction. Got it? So this way, you have to identify from the flow volume loop that which one is emphysema, which one is restrictive disease. Okay. Now at the end of this discussion, we are going to discuss that how the flow volume loop will change in upper airways diseases. Try to understand. So far we have discussed the emphysema and the fibrosis. So emphysema and fibrosis means there is restriction and obstruction at the level of lung. That is a smaller airways. But what about the bigger airways? If there is obstruction, if there is problem in the bigger airways, trachea, bronchi, major branches of the bronchi, then can you diagnose with the help of low volume lip? Answer is very, very yes. So, the upper airways obstruction disease is divided into like this, that fixed upper airways obstruction and there is variable upper airways obstruction. Fixed upper airways obstruction means the obstruction will causes problem both during inspiratory phase of the respiration as well as during the expiratory phase of respiration. So, both inspiratory phase and expiratory phase there will be problem in the flow volume loop. Okay. But variable obstruction means the problem will be either in inspiration or either in expiration. Okay. So, variable extrathoracic obstruction means the problem, okay, will be during the phase of inspiration. Problem during the phase of inspiration. I will explain. And variable intrathoracic obstruction means the problem will be mainly during expiration. So, the problem mainly during expiration. Getting my point? So, extrathoracic means inspiratory problem and intrathoracic means expiratory problem, inspiratory problem. Okay. So, this way I have to remember. Now, you try to understand. So, again I am going to show you the normal curve here. So, on a left hand side you are getting the normal curve. So, there is a smooth expiratory portion will be there. Okay. There may be a little deviation, but mostly it is smooth. There should not be any scoop out of appearance. Now, you are seeing a curve on your right hand side where the inspiratory smoothness of the curve is flattened and the expiratory curve is also flattened, means the curve is looking like a box pattern. So, this kind of box shaped curve, box pattern is typical of fixed upper airways obstruction. So, take the examples of the fixed upper airways obstruction. What are the examples? Foreign body in the trachea, scarring of the airways, enlarged thyroid gland. So, if this is happening, foreign body obstructing the trachea. So, foreign body means it will cause obstruction during inspiration also and during expiration also. So, both the phase of inspiration and expiration, which are supposed to be smooth, which are supposed to be smooth like this, which are supposed to be smooth like this, the smoothness is not there in this curve. There is a flattening of the curve. So, this box shaped curve is known as fixed upper airways obstruction. Now, variable extrathoracic obstruction. So, variable extrathoracic obstruction means first you look at this diagram. So, suppose this is your alveoli. Suppose this is your alveoli. Okay. Rather than alveoli, we should draw that this is the trachea and divided into bronchi and bronchioles, and this is the thoracic cavity. Okay, thoracic cavity. So, if the obstruction is happening outside this thoracic inlet, okay, so if the obstruction is happening outside this thoracic inlet, then that is known as the variable extrathoracic obstruction. Like for example, if you look at this example, paralysis of the vocal cord, enlarged lymph node, okay, flabby pharyngeal muscles. So, if there is a paralysis of the vocal cord here, paralysis of the vocal cord here, so what will happen? Whenever the person will take inspiration, so inspiration means there will be expansion of this thoracic cavity. Whenever there is expansion of the thoracic cavity, air will be sucked inside this lung, air will be sucked in. So, whenever the air is sucked in, along with that air, the vocal cord will also be sucked inside this trachea or bronchus. Okay, trachea. Vocal cord will be sucked inside the trachea. So, because the vocal cord is sucked inside the trachea during inspiration, what will happen? The inspiration is not going to be smooth in variable extrathoracic obstruction. Getting my point? So, that's why if you look at this curve here, there is a flattening, there is a plateau in the inspiratory portion of the curve. Generally, the inspiratory curve should be normal like this, but it is not happening here. But if you look at the variable extrathoracic obstruction, so same diagram, suppose this is major bronchus. Now, variable, so this is intrathoracic, variable intrathoracic obstruction. So, what is going to happen here? Okay. So, there is a problem at the level of this trachea. Look at this diagram. So, the problem here is within the thoracic inlet, that is intrathoracic obstruction. So, in these cases, whenever the person will take inspiration, there will be expansion of the thoracic cavity. Along with that, there will be expansion of this part where the enlarged lymph node or tumor is there. So, if there is enlargement or if there is expansion of these bronchioles, then do you think there will be problem during inspiration? Answer is no. But whenever the person will do expiration in these cases, this obstruction will be more pronounced. So, that's why in case of variable intrathoracic obstruction, the extrathoracic portion of the curve will be flattened, but intrathoracic part of the curve, the inspiratory portion of the curve will remain normal. And what are the examples? This can be caused by various tumor, tracheomalacia. So, trachea is soft and during inspiration that portion is expanded, but during expiration that tracheomalacia portion is compressed. So, that is your all about your flow volume loop and abnormal flow volume loop. Okay. Now we are going to discuss certain MCQ. So, the first MCQ, spirometer recording was given the marked part. So, this is the part which is marked. So, I can easily understand here that the residual volume is also there and expiratory reserve volume is also there, ERV, okay, and residual volume. So, combination of these two is FRC. Got it? Second question, a 50-year-old patient. So, FEV1 is given, that is 1.5 liter, and FVC is given, that is 3.5 liter. So, if I take on FEV1 upon FVC ratio, so this ratio, this will be 0.42. So, 42 percentage. So, 42% is very lower than that of the normal 80%. So, I can easily understand that this is an obstructive disease, typical obstructive disease. Okay. Third question, which of the following increases in COPD? So, COPD, obstructive disease. So, obstructive disease means TLC is definitely going to be increased and residual volume is also going to be increased. So, residual volume has to be increased in your obstructive disease. So, if the residual volume is increasing, then your FRC will also increase and TLC will also increase. So, this was the question given in multiple option, correct option. Okay. So, that's why A and B both has to be correct here. So, this is all about your lung volumes and capacities. Thank you.